Hello, everyone. Good afternoon. I'm Margarita Birnbaum, and I am the Health Equity Core Topic Leader for AHCJ. This webcast is one in a series of topic-specific training opportunities to brief health journalists on the latest information in a particular health area, and to give them story ideas and story resources that they can use in their work. Today's topic is about the toll that racism and ethnic bigotry, among other things, takes on people's health, specifically the health of Black and Hispanic Americans. And this is an important topic that a lot of us are writing about, are looking for information about. And joining us today is author and journalist Linda Villarosa. And Linda is a longtime journalist. She's been a reporter and editor at the New York Times. She is a contributing writer for the New York Times magazine. She was executive editor at Essence, and she's also a professor at the City University of New York. And she's recently written a book that was published within the last 6 months titled Under the Skin: The Hidden Toll of Racism on American Lives and on the Health of Our Nation. And so our guest will present and then answer questions. And with that, I want to welcome Linda. Thank you for taking time today to meet with our members. The first question I have is, how did you come to the idea of writing this book? Please talk to us about the genesis of Under the Skin.
Thank you for having me. I really appreciate it. I love talking about journalism and am humbled and honored to be with you as peers of mine. The book came about for a lot of reasons. I've been thinking about these issues mostly around the poor health outcomes among African Americans and often other people of color since I was a young editor at Essence magazine in even the late 80s, early 90s. And so I kept having all of this information, and I kept sort of thinking about it differently. The more I reported on it, the more I stopped looking at poor health outcomes from the beginning of life till the end of life as an individual issue, and started looking at the structural and institutional ways that barriers that kept Black people and other people of color from having good health or comparable health. And I think also my New York Times articles were very popular sort of among people in the medical and healthcare field and education and training. And people would call me and say, hey, can I Xerox your maternal mortality story and hand it out to my students? And somebody else, hey, I loved your HIV story. It's really foundational for my class. Do I have permission? I'm thinking, oh, these poor people are making little packets of my articles into a kind of book. So why don't I just make a kind of book myself?
One of the things I really loved about the stories you share in the book, your own personal experiences, and in your interview with Terry Gross, is that you're very candid about the biases that you had at that time and how they have changed. And so could you talk to me or talk to us a little bit about how you challenged yourself and how you continue or may continue challenging yourself? Because I know, I'm guilty of doing that all the time in my own reporting, and in actually the work I do also as an interpreter, which also helps inform my reporting, and that I have to be constantly challenging, stereotypes and tropes that I may have, in my case, about immigrants or Hispanic Americans. So tell us a little bit about that evolution.
Well, I think when I was writing Under the Skin, I had a really strong proposal and I sold it. There was an auction. It was really amazing. I got a great publisher. But then when I started writing the book, I realized even though I had a good proposal for a book, I didn't have a through line. So I gave it to my neighbor, who's a freelance writer. We have a lot of writers here where I live in Brooklyn. And I said, I'm having trouble figuring out what's the beginning and what's the end of this book. And then she read it and the proposal, and she said, your story, because I had sprinkled my story throughout. And she said, can you tell your own story and link, how you changed from beginning to end of your reporting as the beginning and end of this book? And that's what I did. And it really worked well. And I don't really I was trained, I went to journalism school, trained back in the, old days to not put myself in stories. So I do it reluctantly. But I also think that it helps sometimes if there's the myth that only the poorest, most marginalized people suffer in the hands of the healthcare system, or discrimination in society. And then, I put a story of my father, who was a college educated scientist who got treated really badly in the healthcare system. I talked about my own experience with pregnancy and childbirth and how I was very surprised to have a low birth weight baby, given, my access to healthcare and my own education. So sometimes it does help to sort of push away from the myth that I'm, and an unhelpful myth that the only people who have poor health outcomes in America are the most poor and the most marginalized, who do suffer the most, but that's not the only folks who have trouble in this country being healthy.
Have you talked to the playwright who was inspired by your story in the Times to write the play Weathering in St. Paul?
No, I'm so interested in that because my cousin is a playwright in Minneapolis. So I'm very interested. And I think Arlene Geronimus will be interested because her book Weathering came out yesterday. So I love that. I love when, sort of journalism and art intersect.
I do too, and I'll send you a piece that we published about that. And that's one of the things that he said in the interview, that his characters are middle class, college educated, or upper middle class American women, Black American women, and that that's one of the reasons why he was moved by that, because he didn't want he wanted to show how this affects everybody, in independently of class or education. So talk to me about how to find sources. How can we find sources to reflect, the reality of that? What are some of the ways that you thought about finding sources and vetted them for both the story that wrote for the New York Times magazine a few years ago, and the book?
Well, I think, there's two kinds of sources. So one of the kinds is experts. So what I try to do is, I came from, I worked at the New York Times newspaper, and I noticed that we were using many of the same experts over and over. So I really made it a mission of mine to find people who were less known, or who sort of their research wasn't as lifted up as other people. So I'm really big on that. I found Arlene Geronimus, and I remember I first interviewed her. She's the person who coined the term weathering. Now she has a book about it, but before, when I first talked to her, I noticed that she was very casual with me. So finally I said, I'm from the New York Times. I'm working on this story about maternal and infant mortality. This is the New York Times. And then and she's like, yeah, okay. But what I noticed was she wasn't used to being interviewed. And because her research really wasn't out there. And so what I try to do is find people like that. And they're often the best people. And they're, even if they've had a really good study that hasn't gotten a lot of play, their footnotes are amazing usually. And I'm really interested in, people's footnotes. I think for, people whose lived experience matches whatever story I'm trying to tell, I usually go with someone who is working with patients. So a patient navigator, a doula, a community health worker, someone like that who has a very hands-on, they're a trained professional with a hands-on connection to patients or people in communities.
And I want to take a minute here to remind our audience to use the Q&A feature at the bottom of the Zoom screen to include your questions. We will address them toward the end of the webinar, and please feel free to ask on the Q&A feature, not the chat. So how have you cultivated sources when you're reporting, where you're interviewing people all over the country? What are some of the ways that you cultivate sources, especially about such a difficult experiences? People are sharing very personal information with you, like the stylist in LA who thought about killing herself and stopped. I mean, that was compelling. Among many other stories, but how did you find her, for instance, and how did you nurture those relationships as you were reporting for the book?
Well, she was very interesting, Audrey Briand, and she went to the same college I did. And she had done, this is rare in our college, which is predominantly white, but there was a sort of a webinar like this, but it was about talking about mental health and Black women. And I was so surprised. So I went to it and I heard her, like I tuned in during the pandemic and heard her speaking about it. So I reached out to her to say, oh, I'd like to hear more about your story, because by the time I got to her, she was more on the other side of it. In that same chapter on mental and emotional health, there's a story of Mark McMullen, who suffered from bipolar disorder for years and years and years, until he had and drug use, and he was murdered by the police in a really unfair way, and did not, for years, wasn't able to get treatment for bipolar disorder, partially, I think, because he's a Black man, and there's an assumption that, that either he did not want to seek treatment, or was afraid of treatment, or couldn't find a provider that looked like him, or that there was the assumption that he didn't need it, or whatever the problems were. And he is my friend's brother. And so I had never really heard the whole story. And I asked her if I could go interview her mother, who still lives in Connecticut, and go through his, he's deceased, so his boxes and the police reports. I got all the documents, but partially because I had a relationship with his family.
Had any of your sources ever been interviewed by reporters? And if they had, what did they share what those experiences had been?
I was doing a story on COVID and racial disparities in COVID for the Times Magazine. And my editor said, oh, I really want you to interview this physician from Northwestern University. So I was like, how do you even know him? Why? And then she said, I just think he has a good take. He has an essay in the Journal of the American Medical Association. So I looked him up and I was like, okay. So I call him, and I've read the study really completely. And I said to him, the first question I asked her, what are the women at the bottom that you thank? At the bottom of the study, he said, oh, those are my daughters. They were my copy editors. And that really had him open up, because he talked about the daughters. Then we worked backward. I found out he was from Tulane. He went to Tulane University, and my story was taking place in Louisiana. So he was an expert, but he was also someone who had lived in the place where I had, been doing the reporting. And I remember when he hung up, he thanked me and he said, you are really with the Times? Because usually when I'm interviewed by media people, it's always a transaction. They've put no work into finding out my history or who I am, and also it's harder. I just feel more tense, and I'm just trying to get the quote out. And it was funny because he had the quote that ended my book. So I used part of that interview as the last lines in my book, because he was so smart and comfortable with me.
So what was it that you think helped him feel that way? And what are some of the things we need to be thinking about when we're either interviewing experts like that researcher, or just people that we're asking to share their very personal stories?
I think when I'm interviewing researchers, I start with, how did you get involved in this? Why is this your area? And always there is a story from the past. And I remember I was interviewing a woman, it was about asthma. And she was using community health workers at a hospital in Philadelphia. And I said, how did you end up, what from your background made you want to do this project? Her grandmother was a traveling nurse in a small town in North Carolina. And she would go with the grandmother and realize the importance of being in people's homes to help them be healthier. But if I hadn't asked that question, I wouldn't have known that history. It wasn't, she had been there, she had been interviewed before, but I had never read it, that's how she started her program. So I usually try that with experts and with sort of people whose lived experience or affected folks. I try to go to where they live, either, sort of research it or go there myself to understand their community and themselves as a whole, rather than just, if I'm going to spend a lot of time with people, I want to understand where they're coming from. And so I guess we would call that the social determinants of health if we were public health people. But just to understand, where do they live? Where are they from? Who are their people? What are their communities like? Who do they love? Where do they go to church? That kind of thing before, even if if my story has nothing to do with that.
Could you, take us back to when you started reporting on health equity issues and how you've seen, the way that the reporting is done has changed, the context that is added, and what's the good and the not so good that still remains, I guess. And so I'll start with that.
Well, I think and I'm part of it too. I'm not saying that I'm perfect and that I didn't change myself. Is early in my career, when I was looking at these, racial health disparities or health disparities at all, I was thinking about personal responsibility much more than I was about structural and institutional issues, and not thinking so much about barriers, but just trying to, with kindness, I think, trying to help people, educate them to how to do better. And then thinking that if everyone does better and takes perfect care of themselves and goes exercises and, does all the things, eats right, does all the things that they're supposed to, then everyone will have good health without looking at the barriers. And I think right now I'm seeing much more in health reporters in general to look at the societal barriers that keep people from being healthy, and to sort of, at best, have a combination. So sometimes I get so into the barriers of, especially around maternal health, that I scare people, and people are, I've had women say, do you think I should not have a baby because it's so dangerous? I was like, no, no, no. Most people who have, get pregnant and have children are fine. People aren't dying in droves, but people are dying much more than they should be as a result of birth. The numbers are rising in the US, and Black women have a greater chance of having a birth go wrong. So I say those things, but I'm saying you should still do all the things you can to have a healthy pregnancy. But, I also want to not pretend like this isn't going on.
We had a panel at our annual conference in St. Louis about adding health equity context about, in our stories about health. So adding information about, the barriers to healthcare and social determinants of health, and, what the zoning policies, for example, the way, cities have approached development, economic development in their cities, how states have approached health policy. I live in Texas. So there's a lot going on here. So what are your thoughts about, how often and how much context should we include in stories that we may be writing, maybe as daily publications, whether they're local or regional? But what are your thoughts on that?
Well, I think that it's hard once it's hard to unsee the policies. Once you know the policies, the past about a place, or about what happened to people, it's hard to not include that if you know it. I'm thinking about, I was writing a story about life expectancy as part of a package for the New York Times Magazine. And, once I understood, people live to age 60, I was reporting on the greatest life expectancy gap. people live to age 60 in south side of Chicago, and they live to age 90, 9 miles north. So I'm, looking into why would that be? And certainly there was a lot of, in some media blaming people and saying they're not taking care of themselves, or there's a lack of healthcare facilities. But then, which was true, that, there was a lack of healthcare facilities, but that was not the reason people were living only to age 60. If you look back at the past of the south side of Chicago, it was redlined, all the Black communities. And then also it was subject to contract buying, which meant you couldn't buy in the 40s and 50s and 60s. Even you couldn't buy a house if you were Black except on a contract. You couldn't get a mortgage. And that meant that if you lost your place, if you lost your home, you could lose your home if you missed a payment. So that, I was reading a report and it said that sapped $3.5 billion away from the Black communities of Chicago. So then you know that, and then it's like, well, that makes sense of why people live fewer years, because they lack access to jobs, to safe space, to quality housing, to all kinds of things that make you healthy in general. So now, if I know that, it's hard to write about, sort of these health disparities without thinking through what were the reasons. And I'm gonna, say my editors at the Times magazine really pushed me to say why, what happened, and what in the past influenced today, because I wasn't doing that as much in the past. But now that I'm at the New York Times Magazine, that is a requirement for me in the stories I write.
Covering health, especially health disparities, can be a real beatdown, because it just seems like it's all bad news, all bad trends, in particular when looking at Black and Hispanic Americans, right? And people who are maybe living in poverty or low income. So how do we as reporters avoid, tropes and stereotypes and just maybe that may contribute to that, and how do we stay away from that and look forward and offer solutions, I guess, or look. And so I'll leave it at that.
Well, a stereotype is just a generalization about people. And I think the opposite of a stereotype is reporting deeply and understanding individual people. And that's the kind of, that's sort of people with lived experience. If you are, no matter what their economic status, race, culture, language, if you understand them and you really do the work to get to know them and to understand the sort of barriers that they face, as well as the resilience and the positive about their life, who's in their life, then you don't stereotype people because of the specificity and detail. I think the other thing that I think it really helps to really understand communities and their history, and to do deep reporting. So you're not stereotyping, you're not, it's not all negative. And there are good happy stories, I guess, or more positive stories. One that really excites me is sort of the rise of of medical students, nursing students, midwifery students, people in public health students, who are really trying to make a difference. And they're really doing a lot of interesting activism, and they're really smart, and they're having to do it at the same time. They're just trying to get their medical degrees or nursing degrees. And I'm very, encouraged by, people like that. I think that's a good news story. And you can find, certainly, and I don't mean, looking for, happy news, but certainly not as negative or solutions based, or something, moving the needle forward.
You're teaching up and coming journalists, and how do you encourage them to learn more about a community that our membership can take away? How do we not parachute into a community, especially for those of us or members who are writing about local health trends and local health or community health? How do you suggest that they do that and stay in touch with the communities that they're writing about?
Well, it's interesting because I teach at the City University of New York, and I also graduated from there. And part of our mission there is to really do hyperlocal reporting, to teach people. So you have to cover a community in your first year, or definitely your first semester at the school. And my community was Fort Greene, Brooklyn. And I live in Brooklyn as well, but not Fort Greene and Clinton Hill. So I rode my bike over there and rode around to get to know the community. I went to the community board meetings, and I was not happy about that all the time because they're at night. And I graduated 10 years ago. I'm like not a spring chicken to be riding my bike around in the night at these community board meetings, but I did learn the community, just really delve into the culture, get to know what was going on. We went to outdoor markets, gardens, all kinds of things to get to know people. And I really love that about our school. And I teach feature writing. So, and I'm really happy about the ideas that my students come up with because they've taken the time to get to know the community. For me, now I learned that lesson. And so I try to bring that into my national reporting because I often center on a community. So I try to do as much as I can. I have the luxury of having, months usually to work on a story and a travel budget most of the time. And I really try to do that work and put in that time to get to know the community. And sometimes I know this is a quick trick is to go with the photographer. And I sometimes will go with the photographer for the first time, or I will take the photographer around and look at the community through his or her eyes. Is a whole different experience.
So what are some things that you would like to see more of in stories about health equity issues? Whether it's in stories about heart disease and stroke trends, barriers to cardiology care, or maternal and mortality, or diabetes and obesity trends, for example, or food access to food.
And I think if you're doing a story on obesity, you have to do access to healthy food. You have to do if you're doing obesity in children, you have to look at the school system and say, oh, what are the kids eating at lunch? And my students were, last semester, I had one. She was really interested in sort of obesity statistics in children in New York. And then she turned in the story and had kind of this little low-key blame, oh, kids are always eating too much. And I said, okay, you're going to have to go back and look at the school menus and look at what kids have access to in schools and look at how much physical education they have. They're spending most of their day in school. So how are schools trying to make this, change this trend? So I sent her back, and it was really interesting. And she was from the community, but she had a sort of a layer of blame around some of the children and their parents. And I said, go back and just see what are the structural issues. So I think if you always think, that's got to be part of this health equity story. And I think also history is really interesting. I was part of the 1619 project. So during that, I really delved, it was all history except the through line to what was going on today. And the history always led to a through line, to something that still exists today, a myth or a stereotype or something negative in the healthcare field, and sometimes something positive. Like if you're talking about doulas in America, there's a history of, Black doulas in the South who were caring for enslaved people and then caring for people who were left out of the healthcare system. That's a lovely story, but, about doulas, if you're writing about that, but you always have to, in my stories, I always try to put the history. Where did they come from? They didn't spring out of nowhere. There's almost always a history of something that happened, or someone, or some legacy left over.
Well, I want to remind everybody to place their questions in the Q&A. So we'll be watching for those. And as we wait for them, I wanted to ask, are there any topics that you would like health journalists to be writing about more, or a specific kind of context that you'd like to see more of in health stories?
I just have a lot of respect for local stories and for what's going on the ground in places where I don't live, which is every place except Brooklyn. And so I love that. I love what, even when reading a national story that starts in a local place and then nationalizes, and how is this place representative of a bigger issue. I love kind of issues-oriented stories. I think that we are going to have to continue covering, unfortunately, maternal health, because the maternal mortality statistics went up during COVID. I think also life expectancy is, I find, really interesting and sad, because our country has the lowest life expectancy compared to other wealthy countries. And it's across class and race lines, where life expectancy is not good. Mental health certainly is one that I'm very interested in. I'm super interested in what is happening in communities and how they're trying to, on the ground, work on mental health issues. I know a little bit of what happens structurally in New York, about how we're dealing with it. And my students certainly covered those issues. So those are two that I think there's a lot of promise. I think epigenetics, I get asked about a lot. I haven't delved into that topic yet, but I think there's a lot of growing interest and growing research in that area. ACEs is one, adverse childhood experiences. Most pediatricians do not use ACEs in their work. So in other words, if you're a pediatrician and you just sort of are looking at the body of a child, and without looking into as much of their history or where they live or what has happened to them in the past, I think California is doing a good job with that. I think anti-racism and implicit bias training among healthcare providers is a super interesting topic. There's certainly growing movement in that, without not a ton of reporting on it, and also not, the early evidence is coming out, whether it works or not, and what kind and how textured it is. I think these are all story ideas I wish I had time to do. But I'm, really interested in those topics.
So you've trained journalists around the world. I was reading that in your bio, that you've trained journalists in Mexico, in Europe, and in other countries. And how do we compare? Do you have a sense about how journalists in the US compare to their peers in whether it's developing or developed countries like ours on health equity reporting
I think,
and addressing the racism and prejudice have affected health?
well, most of my training has been specifically on HIV. And so training journalists from everywhere how to better cover HIV wherever you are. And I think that I think a lot of times we are teaching other people how to do a thing without asking them, how could we better do the thing? And what I noticed in, when teaching about HIV and with journalists in developing countries, is how they have managed to do really some interesting reporting with little resources. And I think that's really good for us to understand. I remember I was talking to it was an audio journalist, and I was telling him about how, how to sort of like find stories about HIV, the best way to cover it, the science around, where to get the best science. And he was telling me how he did his recordings, and, everything was DIY. And I was really struck by how sort of persistent he was with so few resources, and inspired by that. I think, we can always learn from other places. And I think that sometimes we just assume that we do everything the best, but certainly that isn't true.
What are some of the challenges you have faced in doing your reporting? Well, and then specifically in doing, I'll kind of qualify that, in doing the reporting for this book. What are some of the challenges you faced?
COVID. So I started writing in 2018. So I think exhaustion, like, I have a teaching job. I'm a contract writer, a contributing writer for the Times Magazine, and those are really hard stories. So when I got the book, I was really exhausted. And then I was a little lost about the through line. So it took me a minute. Then COVID happened, and I was reporting on that, plus trying to still get the book done. And then I was in trouble because the book was late. And I really couldn't travel very much. So I was doing so much more on the phone than I had planned to do. Then I did travel, scaring everyone in my family by traveling to West Virginia during the height of COVID to talk to people with HIV, people using drugs. And there was an HIV outbreak related to heroin. And so I went. So that was a huge barrier. It was just hard. It's also hard to write a book. If you out there want to write a book, good luck. People are always saying to me like, oh, when's your next book? And I was like, oh my God, I just barely finished this one. I'm super happy by the response to it, but it was tiring. And so I think travel, COVID, a pandemic, it gave me so much more to add to the book, sort of talking about infectious diseases. I have a history of writing about HIV/AIDS, finding that many of the same people who were the experts then, or the new experts in COVID, there was certainly much more reporting around racial health disparities by the time COVID, during COVID. So then it became kind of competitive. It's like, oh, I'm not one of the only people doing this. There are other people. I've got to, up my game a little bit.
Well, thanks for sharing that. And I've been wondering if you could share a little bit about what led you to title the book the hidden toll of racism on American lives and on the health of our nation, um, because that implies that all these really just negative outcomes that are affecting other people affect all of us as a society. So could you talk to us about what led you to think of it that way?
I think the health of our nation part happened because I was looking at statistics that said we're the wealthiest country by, of all the countries. We spend more on healthcare than any place in the world. But we have the poorest health outcomes. We have the lowest life expectancy, high and rising maternal mortality, the highest infant mortality of all the wealthy countries. So I'm thinking, why? Why is that? And then what we do is we blame it on poverty only, but then we have the statistics around maternal and maternal mortality that says a Black woman with a college education and even a master's degree, a JD and MD, is more likely to die as a result of having a baby than a white woman with an 8th grade education. So my thinking is, if we did not have this kind of inequality in our system would certainly be, working better. I think also a lot of people say, well, what about universal health care? And I'm like, well, universal health care, we should have that. I believe in, the right to health care. But even if we did, those statistics wouldn't go away unless we change a system that has discrimination baked into it. I did not want to use the word racism. I had race the first round. And then I started thinking about it and I was like, this is not about race or something wrong with Black culture, wrong with people of color, wrong with our bodies. It's about how we're treated. And if, how you're treated based on race negatively is racism. So I had to say it, but we went back and forth. And it was kind of me who was reluctant because I didn't want healthcare providers, especially, to feel like I was accusing them of something. And I just had to sort of get over that because throughout the book, it's clear that I'm not doing that, but I didn't want to make people feel bad.
Have you ever had a doctor or researcher push back or become defensive during an interview and because they feel blamed? And if you have, then, how have you dealt with that?
I had a whole team, a room of a grand rounds where the physicians started pushing back. It was they were OBGYNs. But what they were saying wasn't true. And so it was in a Midwestern hospital, and I was doing the grand rounds talking about these issues around maternal and infant mortality and Black Americans mostly. And they were saying things that weren't true. They were saying, well, it's a genetic problem. and we suspect it's genetics. I was like, it's so well proven that it is not genetics. And I told them about the study that once and for all, it wasn't even that new, proved that there is nothing different about Black people's bodies that make us more prone to having, I mean, not nothing, but that isn't a thing. It's not largely a problem of genetics. Then it was sort of like, well, it's that we noticed that our patients aren't, a list of bad habits that they said their patients had. And also that Black women tend to come in by themselves and they didn't have a sense of kinship. I said, kinship is not what kills babies and mothers. That is just simply not correct. And I was insulted, actually. And what I noticed was in this room, we went back and forth and I sort of tried to correct them, but it was hard with, 12 to 1. And then I remember saying, what I noticed is that there are 12 people in this room, and one of us is a person of color, even though you seem like you have a lot of patients of color, and I'm that person and I don't work here. So I think that rather than try to argue with me over things that you can just, if you don't believe me, look at the data in my stories and book, then, look at yourselves, because it certainly research shows that when the provider has more in common, and I mean by race, as the patient, then the patient has a better outcome. And so, I don't like that. I was so upset afterwards. The person who brought me to the hospital, who drove me, could see that I was really, really upset and was saying, do you want to, do you need to take a minute? Do you want to go someplace and meditate? I was like, no, I just want to get out of here because I'm so upset. So, that does happen sometimes, but I try not to. I had it recently where I was on a panel. So it was me, I was the journalist, and a doctor and another doctor at a fancy school. And we were talking about discrimination in the healthcare system. And they said, we just need more evidence of that. And I said, no, we don't. We don't need any more evidence. They said, no, we just need, I was like, no, we don't. In 2003, 20 years ago, 483 studies said that there's discrimination in the healthcare system for people of color, especially Black people. They are doing a look at it 20 years later, and not that much has changed. There's still discrimination. And if you don't believe the report, then talk to real people. They will tell you their experiences. So, again, I don't like to be the one, but also I try to, not go too crazy and try to stay in my role as a journalist. But, sometimes if people are just saying things that are incorrect, it's just upsetting.
Okay, so we have a question, and the question is, how can we practice more cultural sensitivity in our reporting?
I think that learning, I have this semester, it's very interesting because the students, there's a couple students who are reporting on the South Bronx, and they're both the white students. And they were talking about feeling out of place. And I said, if your heart is in the right place and you know the community and you are respectful and you you're familiar with the cultures and the customs, you're not just going in and doing your reporting. Maybe on the weekends, you're going to the, outdoor dance party in Van Cortlandt Park in the Bronx, or you're, eating in restaurants so you understand the culture and the people and you're listening. I think that's the best way. And to sort of, doctors think a lot about this as well. They think, how can I, practice cultural sensitivity? And I think that what everybody needs to do is just be good listeners, just try to, treat people like people and not think about the differences, and just think about what you have in common and how you can understand people better, and customs and cultures and communities.
So how can reporters explain to editors who may not understand the value of taking that time to get to know their communities, that this is important, that being on the ground, that not walking around with your pad all the time and not parachuting into a place is important, and that it takes time and that it'll pay off in the long run?
Well, I think that I think that there is more of a trend toward that now. So you look at, I mean, I'll just say, like, if you look at the stories, that win awards, they aren't the stories that somebody has parachuted in. They're the story, unless it's spot news coverage. It's the story where someone has really spent time getting to know the community, no matter, like, even if it's one that they're not from, they're not of. And I think that I think there's a growing understanding of that. I think part of it is, in our business, we are ruled by deadlines. So that is the tension that happens. And I think one way to do it is, I say to myself and my community, I was riding my bike around those communities, not on my own time, so I understood, because I know that's the value. So part of it, like, I don't know how people convince their editors of things. I always am trying to figure out how to make my editor do what I say. And it doesn't always work, even though I love her and the other editors that I work with. And so I think part of it is, what, I'm going to prove it by just knowing that this is the right thing to do and doing the best kind of work that they value. And when they ask me, how'd that go? I spent a lot of time in the community getting to know the people. That's why this is such a textured story. I went around with the photographer you assigned to me and tweaked the story after I had seen it through his or her eyes. And so I think success is a good way to prove your point.
Well, Linda, the last question that I'm going to ask today is there anything that I should have asked that you think I should have asked and I didn't?
No, you did great. Thank
Thank
you.
you.
But I just want to say to everyone, I know there's a lot of freelancers, there's a lot of people, sometimes it is hard to talk to editors. I've been doing it a long time. I've had times when I got pushback. I was working on a story about HIV, and I really was having trouble having the editor believe that it was still a problem in America. So this was a little bit ago. And I brought another reporter. I didn't give up, but I wanted to, because I was upset that they didn't believe me, and brought another editor in with me, and the two of us partnered. And that was one of my most favorite stories, was working with someone else and having a collaborator. I think especially when you're a freelancer, I freelanced for many, many, many years. It's always helpful, I think, to have an organization like this, to have groups like this, to have information, but also to have friendships and collaborations and partnerships with other writers who are covering the same or similar areas. I found that to be really helpful. One of my walking buddies also does health and healthcare reporting, and the time goes by, that 3.5 miles goes by really quickly when we're talking about work.
So I love that piece of advice. I'm a freelancer myself, and I love collaborating with people when I can. I do it in my work as an interpreter, and I just feel like it makes me better when I'm working with somebody that is talented and can see things that I don't see, and so they add a lot of richness to the work. So actually we do have a question, so this is the last one. We have another question. What do you think is the best way to combat misinformation surrounding health and racism?
I think that is a really bad problem and growing. I saw it when I was reporting on COVID a couple of years ago, and I saw those myths, and I saw the, vaccine hesitancy among Black people and that kind of thing. I think what I do is try to, sort of start with empathy, to say there is a reason that, sort of, especially in communities of color, misinformation goes out there because we don't trust the system. So then it seems like we can, we as people who have been mistreated by our system, healthcare system, and don't trust our system, kind of can latch on to something. I think the remedy to that is getting very good data, and really, that's how I do it. I try to do storytelling that combines people's experiences, a real people-centered, because people like stories of people with real information that comes from credible places. And that's what I do, but I don't do them alone. I always combine those two things so that I can, get people reading the stories or, consuming my work because they know it's going to be a good story about someone that they come to care about, and then to make sure that all of my own work is really credible. So that's all I got, but I know that that's a hard problem, and one that we're seeing more and more of.
Well, Linda, thank you so much for your time. This has been great, and I hope I get to meet you when I'm in New York over the summer. And I want to remind everybody that a recording of this session will be available later today on our site. Thank you all who tuned in today, and the AHCJ will continue to bring webinars on a variety of health topics, and that's one of the perks of the membership and following us. So thank you all today, and good luck on your stories. Linda, lovely to meet you, and have a good rest of your week. Thank you.
Thank you. Bye-bye, everyone. Bye.
Bye.